Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. And Lynn, we're talking heart stuff, heart matters today.
Yes.
It's a very special Health Matters.
Very special. Give me a break. So, it's just something that's common up here.
Now, you say that a lot. Is it common up here? Is it common everywhere? Is it common to rural stuff? Is it a Del Norte thing? What makes it common up here?
Bad lifestyle choices, I think. But that might be part of it. But also aging.
Yeah.
Okay, to be fair, aging. But it also kind of sets up problems down the road that we have a hard time dealing with here because we don't have this, specialties.
Okay, all right. Well, let's dig into it. AFIB.
Yeah, atrial fibrillation, commonly known as AFIB. And what that is there's 4 chambers to the heart. The 2 are on the top are called atrium, and the 2 on the bottom are ventricles. And the AFib, or the atrium, is to kind of smash the last little bit of blood into the ventricle before it either goes off to the lungs, which is important, or off to the rest of the body. So it's kind of like stacking the load there. Okay. But what happens is sometimes instead of the steady lub-dub like we always hope we have, the top part gets kind of irregular, and it's like going by its own drummer, I guess. And so it's not preloading the ventricle, and the ventricle either gets confused and over-responds, so has a rapid ventricular rate as a response, or it goes really, really slow and it's not beating out blood as efficiently.
Okay.
So it's kind of an important player, and when it's messed up, it really causes problems. So palpitation, shortness of breath, heart pain, dizziness, fainting, or near fainting.
Wow.
So, and people, it scares them.
It's very. I've had things I thought was AFib, and there's other like rhythms that can get mixed in,
Right.
But I don't think it has been. And so I'm looking forward to digging into this.
Probably not. Your risk goes up as you get older, though. So
I haven't
could
had
be someday.
All I feel is the motion, the thump in my chest. I've never had dizziness, shortness of breath, anything like that. So.
That's more likely a palpitation, so a premature ventricular contraction.
Wow.
So the ventricle just gets a little excited and then goes rogue just for one beat.
That sounds like me.
and then it like calms down, and the other electrical pathways in the heart are like, just go sit down.
Okay, go in
away.
The corner.
So you can have AFib for a long time and not know it, and it can also complicate other disease processes, especially with treatment, because treatment makes life a lot harder.
So you say you can have AFib for a long time. So this isn't something that just kind of happens and then stops. This can be a chronic.
It can do both. Yes, the answer is yes to that. It can do both.
Okay.
So you can have an acute onset, you can have chronic, and you can have start and stop.
Oh my gosh.
Somewhere in the middle.
Okay.
So who gets it? More common. It's the most common cardiac arrhythmia in the world, which I thought was kind of cool. But
why? Why is that kind of cool?
Because I diagnosed it recently, and I'm all proud of myself for picking it up.
But wouldn't you be more proud if it were the least common one?
Some days it's a low bar there, Paul. Women get it slightly more often, and they do less well with it. But it's pretty much gender male to female.
Okay.
And the risk goes up with increasing age. So your risk is higher today than it was yesterday.
That's wonderful. Thank you.
Yes, well, something to think about at 2 a.m. But people, here's the core of the message. People who have hypertension, diabetes, hyperthyroidism, so a thyroid that's jacked up, COPD, sleep apnea, and heavy alcohol use are more likely to get AFib.
Oh, wow.
And so this is the reason I bring it up in Del Norte, is that a lot of these diseases that I'm talking about or risk factors are modifiable.
Right.
So if you know you have one of these problems, take it seriously, because you're not going to like what they do to your heart. It's going to be a mess down the road. So exactly. I love the fact that so many of these things can be addressed with lifestyle changes. Oh, totally.
Yeah.
So I'm empowering Del Norte to make a change here. So hypertension, look at the DASH diet. That's important. Take your meds. Take it seriously. Diabetes, pay attention to your sugar and exercise. Hyperthyroidism, where a thyroid that's too high, think of a thyroid as an idol of a car.
Yeah, okay.
If it's wound too tight, then, you're getting poor gas mileage. You're revving at every stoplight.
What's it regulating, though?
Huh?
What's it regulating?
It's regulating the metabolism of the body, the pace of metabolism.
Okay.
So like an idle of a car.
Now, is that something that can be affected lifestyle changes, or is this a genetic sort of thing?
Only the lifestyle change that you pay attention to it and get it treated.
Okay.
Some people kind of like to be a little hyper. They kind of thrive off that.
Yeah.
But in the long run, it's not good for you.
It burns you out.
We weren't meant to do that. Diabetes, we talked about that. COPD, so watch the smoking. Sleep apnea, take that seriously. So if your spouse is worried that you stop breathing in the middle of the night, listen to your spouse and, go through the protracted agony that is getting your insurance company to pay for a sleep study and then the proper equipment to correct it if you have sleep apnea.
Okay, so this is a message going out to my ex-wife, Carla, and her relatively new husband. I forget his name, but Carla stops breathing in the middle of the night, and you have to elbow her to get her to keep breathing. So just word to you guys, not my responsibility anymore, but there you go.
Yeah, so take that seriously.
That's
Heavy
scary.
alcohol intake is kind of self-evident.
Yeah.
So this is cool. It's diagnosed by an EKG. So EKG is kind of a written representation of the electrical activity of the heart.
Just had one of those recently, yeah.
Yeah, it takes something really dynamic and puts it on paper. And so you might wonder why healthcare providers get so excited looking at all those chicken scratches. We really learn a lot. We learn about what the rate is of the heartbeat. We learn what the coordination of it is. Is it regular? We learn what's the axis of the heart in the body. That's kind of exciting. Is it a little too big? Is it a little too small?
Oh, wow.
Which part is like having a problem, or if there's a part not getting oxygen. And is it repolarizing? So does it get it all together to do it again in the next beat?
Wow.
So EKGs are kind of fascinating.
I have a quick question about an EKG. Why is
Sure.
it a K?
Because we're not English.
Okay.
Yeah, that's ECG. So I don't know. I was trained EKG.
Yeah.
But it's kind of used interchangeably.
Okay.
And then something called a Zia patch. When I started in medicine, this was called a Holter monitor. So it's just an EKG or ECG. That lasts for 24 hours or 48 hours or a couple of weeks. It depends what time frame you're looking at. And this is important because, especially with AFib, because sometimes you might be in it. And sometimes you might not be. So if the EKG that they do in the doctor's office looks cool, that's because you're cool in the moment. It doesn't mean you're cool in perpetuity.
Right.
Okay. And so a Zia patch is just a increased technological advancement. And they're actually able to take it out of the box in the office now. It used to be you'd have to go to the hospital and get it put on, and it was bulky. It was like carrying around like a small transistor radio, and you had to have
like an external pacemaker kind of.
Right. There's all these like leads going, and people would hate it. But right now, it's just it's like a little microchip that's adheres to your body,
Like a little patch, like it was stuck on you. That's great.
Yeah, it's super cool, and you can set it for 2 weeks. You can set it for an event monitor, which means like if you're aware something's happening, then you make note of the time, or you press a button and the person reading the results at the end can go, oh, well, right then this is what was happening.
Wow.
Or an exercise stress test, which is where they stress your heart, usually on a treadmill, but they can use nuclear medicine to do that. And yeah, I know, kind of scary, huh? Paul did a scared face.
Nuclear medicine.
Where they can stimulate kind of stress on your heart that causes these abnormalities to be more commonly expressed.
Okay. Why the term nuclear medicine?
Because it involves radiation.
Okay, all right. That's all I need.
Yeah.
I didn't know how they were stressing it.
Yeah, they used to be called thallium scans.
Okay.
But anyway, but they've got a new name now. It's interesting, Zia patch, and then the new name for the exercise or the nuclear scan stress test, both are brand names now. And I talked to a younger doctor recently who wasn't familiar with, I guess, what you could call the generic name.
Oh, wow.
And so it took a while to figure out we were actually talking about the same thing.
Oh, no.
Yeah, I know.
I don't want a Coke. I want a soda. That kind of thing.
Yeah, exactly.
Oh, wow. All right.
So, but you can also find clues on physical exam, and that's why the best people that are the most talented at physical exam can find out so much about you, and it's really an art that's kind of going away. But something as simple as listening to somebody's heart while you take their radial pulse, that's their pulse at their wrist. If there's a discongruity, it could suggest AFib.
Oh, wow. Okay.
I know, isn't
okay.
that
is
a
neat.
little gem?
It seems like that could suggest a whole bunch of things.
It could, but it depends on what you're really hearing, and
Yeah.
that's where the art of physical exam comes in.
Right.
So I think somebody whose provider thought they had this would not only do a thorough physical exam, but a chest x-ray, thyroid function tests, and electrolyte studies, because things like potassium being off, or probably sodium a little bit, mostly potassium, can cause changes in the way the heart beats. So treatment's divided into whether the patient is stable or unstable. If they're unstable, they get cardioverted pretty much immediately using direct current. And
So you get shocked? Is that what you're doing?
yes, that's the Grey's Anatomy moment, but not exactly. It's a different kind of current.
I'm sorry. All I have is a bank of ER moments, and you say Grey's Anatomy moments, and I have no idea what that means. Is that like the shock and clear, stand back, all that stuff?
Yeah,
Okay.
but this is here is a little less frantic.
Well, because you're conscious, right? It's not going to be something like they're saving
You can
your
also
life.
be put under. It depends how unstable you are.
Okay.
If you're super unstable, they're going to apologize later and just get it. But if most patients are commonly stable, and they get put on controller meds like beta blockers, which is a type of blood pressure medicine, but it changes the way the heart beats. It changes the way the vasculature is in the body and how the preload and afterload and things like that.
Wow.
It's super complicated and kind of fascinating, but maybe meant for another day.
But it just something that affects like that the functioning of the entire vascular
Right.
system.
So you might be on those meds not for hypertension, but for rate control.
Wow,
Does that
okay.
make sense?
Yeah.
Calcium channel blocker, same thing, another category of blood pressure meds, and that might not be used for blood pressure here. It might be being used for rate control. And digoxin, we're all familiar with old-fashioned digoxin.
Never heard of it before.
Okay, so foxgloves, we see them blooming. Probably June, July.
Something like that. Yeah. They're beautiful.
So yeah, this is
Digitalis? Is that where we're going?
digitalis.
Okay,
This is a medicine that is derived from nature, directly from nature. It's been used for a long time. Not used so much anymore because it has some toxic side effects if you amp somebody up on it.
It can be poison, right?
Yeah, it can be.
Yeah.
So
Okay.
but anyway, sometimes people go on that. So the reason that it's important to get it treated, I mean, what if you're walking around and you're an AFib and there's really no problem, but when the blood isn't flowing through the top part of your heart correctly, it's forming clots. So what does blood that gets caught in an eddy do or sits still? It clots. That's what it's supposed to do. So, and if you have clots within your atrium, or if they move within the ventricle,
Oh, wow. Okay.
then they get pinged out to your brain at some point.
Just throw a clot.
Or
and there
your
you go.
lungs.
Wow.
Yeah. So anticoagulation, this is another reason I'm talking about it, because it's a hassle to live with it. So anticoagulation is an important part of this. And when they anticoagulate somebody and with what is kind of a complicated, needs a lot of data question. Okay. But there's a lot of different types of anticoagulation. We used to really only have aspirin and rat poison.
Rat poison?
Yeah,
really?
warfarin, also known by the brand name Coumadin.
Oh,
is
okay.
essentially rat poison.
Oh, my God.
And that's why it's so closely monitored. If you're on it, stay on it. Your doctor's got this. Don't get all freaked out. But that's what it is.
Oh.
And then there's newer anticoagulation medicine, which might be considered safer, but certain ones are more appropriate for certain clinical situations. But here's why it's a hassle. If you're taking anticoagulants and you have a higher than expected bleeding potential, then stuff can start to happen to you, and patients get annoyed because they get bruises, but you could also get gastrointestinal bleeding, for example, or if you hit your head and fall. Somebody on anticoagulants, their risk of getting a brain bleed from trauma is huge.
Wow.
So the first thing is keep taking them like you're supposed to. And the second thing is make sure that you get prompt help if you think something like that's going on with you.
So I mean, we've talked a lot about what to do and how this can affect you. What causes it?
What causes AFib?
AFib, yeah.
Aging, your heart, just the electrical.
Is it just a condition that like a number of different factors can cause?
Right, it could be multifactorial. Some of those factors we talked about and you can control and some you can't. Like, I mean, aging is kind of a good thing, right?
Well, sure, but you say aging causes it. All right. Physically in the heart.
So you get miles on your tires. So the electrical capacity of the heart, which is how energy moves through the heart, and when things know when to do this thing and not that thing.
Right.
You know, when to move, when to sit still,
Just
stuff
the
like that.
rhythm of it, right, sure.
Yeah, the rhythm of it. And those fibers get worn out,
Wow.
I think, after a certain period. But it's also, other things that we do to trash our body. It doesn't kill us right in the moment, so it must be good. But you always, the body doesn't forget. You pay the piper at some point.
Yep.
So consider what modifiable risk factors you have as you're aging, and try and make those no longer an issue with you if you can. But there's miles on our tires. All of our body wears out, like with our joints wear out.
Yeah, no,
miles.
we were talking about this a couple of episodes back.
Our brain wears out. The cleaning crew in the brain doesn't work as effectively. There's all kinds of things. It affects the heart. It affects the lungs.
Yeah.
And so it's important because all of this is tied together. So if the heart's not beating normally, then the lungs aren't working well either. So it's an important issue in medical care here because it makes medicine just that much more complicated and without any subspecialty support.
Without any subspecialty support. What do you mean?
So there's no cardiologist in town.
Oh, wow,
what if you have hard to control AFib? I mean, most of the primary care doctors here can manage it quite nicely. But what if you're special or something and you have harder to control?
Can you talk at all about? I'm sorry, I interrupted. Go ahead. I'm sorry.
Go ahead.
Can you talk at all about the diagnosis you came up with that you found when you said recently you diagnosed AFib? What was the
how I picked it up? I was maybe even shown off a little bit, but it occurred to me that I could listen to her heart and take her pulse at the same time.
What you were talking about, okay.
And I just wanted to see if that worked.
What did you
guess what? It did.
What did you hear? Can you describe what you hear?
Well, if you're feeling, you should feel the pulse the same time you hear the heartbeat, especially the second heart
So
sound.
if there's a delay, you've got something going on?
Yeah.
Wow.
Yeah,
okay.
there was no coordination.
Huh.
And so, and actually she went on to have, went to the cardiologist. I started her on rate controlling meds and anticoagulants. She went on to the cardiologist who wasn't convinced about the diagnosis. He did more intense monitoring of it and found it. So it verified what I was hearing. And I was just lucky that it was happening when I was standing there with stethoscope in hand. So that's not like a huge medical moment. That's just dumb luck.
Well, no, but you were there and you knew, you recognized that moment and you made the most of it.
You have 7.5 minutes. I think a lot of providers would not have thought of doing that.
Wow, okay, yeah.
If they weren't cardiologists.
Yeah.
Or they were feeling pressure outside because, somebody else wanted to be seen that minute or, whatever.
Wow. There was one of my children had a heart defect. And it was what was it called? An atrial fistula? It's basically a hole. And what ended up having to be done was a Teflon coated spring placed in the hole. Then platelets start catching up on that, and it basically covers. It's
made like a little patch,
a little spackle.
a little bit of technology, a little bit of human luck. Yeah.
Right. But first off, we did it all at OHSU, and they go in through at the time she was like 6, right, and they go in like through the leg and go all the way up and do all of this stuff. It's just amazing.
I'm sorry you went through that, but
it was a hell of a 40.
Cool.
It was a hell of a 40th birthday I had actually up there, and but it was the doctor afterwards, because about a month later or so we go back up for a checkup and everything's been fine and this worked and all, and he asked who picked this up, and there was a physician here. And I forget his name because, again, this has been like 16 years. A physician here who had just listened and heard what anybody else might have considered a heart murmur. but he knew just from the sound, there's something different about that.
Oh, God, heart murmurs are so amazing.
What do you amazing how?
To hear the sound of a heart when it beats, especially when it's beating aberrantly for some reason. Yeah, a murmur is a sound.
Yeah.
And it's sometimes a vibration. Like I picked one up on my dog just by palpating. And so what he had at that point was a murmur that was so bad that it was what we call a thrill. I know, medical terminology. So so just him resting on my leg, I could feel the thrill on my leg.
Oh, wow. What's a thrill? What's that feel like?
Is like a murmur that's not really something you hear, but something, it's like a vibration.
Wow. Okay.
And you'd have to know a lot of normal to recognize that it is abnormal. And I'm so don't do veterinary medicine, but when I went into the vet and I said, look, this, and I just described it in medical terms, like he was a human, and they picked it up.
Wow.
So yeah,
that's amazing.
Yeah. So,
but I'm sorry, I'm going to finish this with the doctor up there. This big fancy surgeon guy wanted to know about what doctor here in Del Norte identified this because he was going to write him and go, good job. That's amazing. Super
cool.
Yeah. I wanted to get that.
That's great to hear. And then, but the other thing too that I immediately thought of is when you said you went up to OHSU, you guys probably had insurance, I'm guessing at the time, because it would be hard for somebody in the northwestern corner of California. A kid with a heart problem pretty much is going to UCSF, maybe Lucille Packard, which is Stanford.
Okay.
And they have a physician a pediatric cardiologist who comes up from UCSF, and he's like aging out of medicine. He keeps trying to retire, and there's like nobody to do it. So he keeps doing it.
Oh my gosh.
And so that means like when I listen to a newborn baby, if I hear something and it's verified by the physicians that I work with, that's a trip down to UCSF.
Oh man. Yeah, no, we had insurance.
That's a big deal.
It was still the big deductible and everything, and it ended up being like a $55,000 surgery.
Right.
And arthroscopic, wasn't a big, nobody
it's not
cracked
like
it.
they cracked her chest.
Exactly.
Yeah,
but that was the next step if they had to, if they couldn't make this work, and they got it to work. And it was just, that was a hell of a day.
But especially difficult diagnosis that was finessed in a place with no resources.
Exactly.
No wonder that doctor was impressed.
Because of a talented individual.
Right.
Which is what you need up here.
And you have to take a minute and listen. It's like, when you go underwater, like in a pool, and sounds different. That's what it sounds. That's a little bit what the feeling's like when you put stethoscope in ears.
Oh, wow.
Yeah, I feel like I'm physically going underwater and listening on a whole different plane.
Gosh. Yeah.
It's trippy.
That's true.
Anyway.
That's interesting. That's really
super
cool.
interesting. I'm glad she got the care she needed.
Yeah. Yeah, and I don't know if it would have saved her life or anything. I remember the doctor in the exam room when we were first up at OHSU and talking about, do you ever have any trouble keeping up with your friends on the playground? No, it didn't affect her at all. Right. It was just this guy heard the murmur and knew it was a different kind of murmur. Because I guess there are murmurs you have and you grow out of. They're almost run-of-the-mill murmurs.
There's some that you have when you have a fever, and then when you don't have a fever, you're all okay. Yeah. So those are innocent murmurs.
See, and that's something we were talking about before this, when we were talking about the topic of AFIB as a topic for today's show. Today's, I don't know what to call them, episodes, segments. I think a lot of people, certainly I do, just assume the heart is just like a machine, like a pump, and it's just going to go ba-bump, ba-bump, ba-bump for 70 plus years, and it's not going to alter or change or anything. But no, it's probably one of the most human systems, and it changes just throughout the course of the day.
Yeah, and we're only talking about a really small part of what can happen with hearts, and both good and bad, and how they work, and in the intricacies of it. I mean, it's kind of like, it's like being in the Utah desert at night and seeing the expanse of stars and feeling very, very tiny, just looking at a heart when you're, dissecting the cadaver.
Wow.
Or even slides of it.
Yeah.
Wow. We are wonderful. What do we call it? We are wondrously made.
Wondrously made. That's nice.
Yeah.
Because there's something special with the heart where it's such an intricate thing, but at the same time, so simple. Just a simple, it's like this simple concept.
Pump.
Yeah, that's it. But it's meat. And that's amazing to me. That's just crazy. All right. Well, what's up for next week?
This is kind of exciting. We're so one of two things will happen. I think what's not going to happen is the Suboxone, which
We've been trying.
Yeah, we've been trying. We have some scheduling conflicts because we'll have guests on, and that's super exciting. But Maria Durazo from Del Norte Community Health Center is just finished her master's thesis on using telemonitoring of diabetics in rural communities, and this would be a service that they're going to presumably offer at Open Door, because she describes Open Door as a stakeholder in this.
Wow.
And she's defending her thesis and wants to come talk to us. So she reached out to us. Super
wonderful.
Cool. Yay, Maria.
And Maria's been on before. We've talked.
Yeah,
What was
my
the context?
favorite can-do person at Open Door.
Was she the? She's the nursing supervisor. What is she there?
She's the idea person. That's what I think of her as.
That's not a thing.
Yes, it is. She
Really? Does it come on her when she gets her pay
she's
stub?
the reason we have the acute care clinic on Saturday. She's the reason we have a PAP clinic that I haven't really talked about very much. She's the reason we have the homeless clinic. She's the reason that the teen clinic is one of the reasons the teen clinic is thriving.
Right, but what's her job title?
I don't know.
You don't know. That's what I'm trying to get at.
It's probably something to do with director of nursing, but that's so limited. Director of nurses are usually kind of like...
This is the woman who is on, who drives down the street and she's got supplies and things she needs in her car and she sees a homeless person. Exactly. Right.
Really, the director of nursing has not begun to identify what she does for this community. Yeah. So she reached out to us and I said, is that even a question? Let's do this.
Right on. So that'll be next week. And then hopefully the week after we can get everybody together for the Suboxone conversation we've been trying to have for a number of weeks now. So I have a question for you. We've got just a few minutes left here. Why can't I go to Open Door? It's the one place I've gone to the whole time I've lived in Del Norte, and now I called this week to make an appointment. And it's been a number of years since I went in for just a regular check, and not something work related like having a TB test or something like this. Right. But and I was told I can't go there because my insurance is wrong because I'm not Medi-Cal anymore.
Yeah, this is a problem. This is a stupid barrier to care rule. Maybe we can get Maria to comment on it, but because she would smash it. So it's part
with
of it
ideas.
Part of it is yes. So part of it I think has to do with how partnership is structured, and in partnership there, if you have that insurance, so that's AKA Medi-Cal, and I'm not suggesting you have it, but
I have in the past. Yeah. I have been that guy.
So you were assigned to that clinic.
Mm-hmm.
And right now, Open Door has more partnership patients than supposedly they can handle. And so what they first did was they stopped taking insurance patients and who had private insurance.
Okay.
So getting private insurance got you demoted. The second thing that's happening is if you were to, or one of us was to apply for Medi-Cal, get accepted, we would be assigned to Stellant.
Yeah, because they don't have the spaces there.
Yeah, because Open Door is full and Stellant is not.
I can't do Stalin. I don't have a Bible.
Yeah, then there's that. And then, so the other problem is that they get such a good deal from partnership right now. You remember how practices were reluctant to take Medi-Cal because reimbursement was like $18 for a visit, and that's not sustainable.
Wow.
So right now it's super attractive financially to take partnership, and that makes regular insurance less attractive. And so a lot of practices have closed their practice to regular insurance. But about the time all this started getting put into place, there were a lot of people on the rolls who considered themselves patients of a particular clinic or a particular office, but they've been well. And so they hadn't accessed care for, it used to be over 3 years, and it was 2 years, and now it's 1 year.
Oh, man. And
because you've been well and haven't accessed care, then they kind of make the assumption you've either died or you're mortal or you moved out of the area or have no reason for health care anymore, which is super untrue, super unfair, and it affected you today, and I'm sorry.
It affected me this week, and I've gotten so where do I go?
They're trying to herd you to Stellant, or maybe to Sutter Coast, or maybe to Blundell's office, or maybe going up into Brookings.
Wow.
Okay. So that's why I always show up at Open Door like once in a while, even for something trivial, so they can keep me on the books, because I'm actually a patient in Humboldt County.
Wow, okay.
But I'm also a patient at UHS, so sometimes it's more convenient to get care up here.
They told me I could come see you on Saturdays.
That would be great.
No, but what I want is I want a checkup.
I know.
And you can't just show up for that on a Saturday, right?
Well, people do.
Can I do that? Really?
Yeah.
The other option I was thinking
It'd be weird, though, I have to say.
Huh?
It'd be weird.
It would be. Okay. Well, but the other option is to go see, I'm not going to Stalin. I will not darken their doorway with my shadow. But
They're already praying for you.
Exactly. Going to a Sutter community is, I know all those doctors too. So it's like
I know.
I got
See,
no place
that's
to
the
go.
problem. That's why
Same with Dr. Caldwell. I can't do that.
I think his practice is closed because his PA is talking about retiring.
And he's still listed. He's still listed on there, but they just may not have updated the Google.
Yeah, I don't know. People make decisions when we can change them. You could go into Brookings. There's options in Brookings. Dr. Silver's a good old reliable guy.
I think it just pisses me off that something administrative and monetary on the back end
You don't like
changed.
being manipulated. I wouldn't either.
I don't like the ground shifting under my feet without me knowing it.
No.
And having it being based upon something that has absolutely nothing to do with my health.
And especially when they're really pushing this medical home thing. They want you to have a medical home.
Right.
And then they
not there.
They change locks. They don't tell you.
Medical latchkey kids.
I bet there's a way to get in there, and I don't know. There's also a lot of things that happen kind of around the rules.
Yeah,
Del Norte does stuff around the rules.
Yeah, we Del Norte it.
One of the coolest things about this place.
It really is. I
So
like that.
smash the barrier, Paul.
Del Norte is a verb. I like that a lot.
Yeah.
All right. Well, thank you very much, Lynn. This was a very, very elucidative conversation. I'm looking forward to the next 2 weeks in whatever order they happen.
Yeah.
All right.
Exactly.
Well, we'll see you next week for our next time. Next week for the next. I forget how I sign off. We'll see you.
Bye.
Bye. It's Health Matters on KFUG. Thanks, Lynn.